Great, thanks PK. I appreciate the invitation. I'm very impressed with the quality of this meeting. Just to add on one thing Dr. Crocchio said is that, as you probably know, data suggests that up to 50% of patients get major amputation without getting a vascular evaluation. And the CLI Global Society, of which you should all be members, has worked with the Leapfrog organization, which provides oversight to hospitals, to create a mandate that no patient should undergo an amputation without getting angiography. So at least that's a good start, and just sort of adds to that imaging conversation, and encourage you all to consider CLI Global Society. Anyway, to get to my topic, this really should be Art Lee's topic. I've liberally used some of his slides, which I've used through the years and never reproduced because the quality of his are so good. Why do we use tibiopedal access? Why not just do things femorally? Or we saw a great case yesterday, a live case which was done for a brachial radial approach. Well, obviously a lot of reasons, and I'm sure you're familiar with this from your own experience. Certainly body habitus is a problem, although we did talk about doing direct SFA access if you're going antegrade. Sometimes you can't cross antegrade in this CTOP classification, which Dr. Mustafa and Dr. Saab, who you saw earlier, helped develop, gives you guidelines as to whether you'll be able to cross antegrade or retrograde based upon the convexity or concavity of that antegrade or retrograde cap, as you see on the right. Sometimes it's not so uncommon. The origin of the vessel you want to revascularize is ambiguous. You just can't make it out, particularly amongst the atherosclerotic pool you see in the parent vessel, and you can't sort of figure out which is an ulceration and which might be the origin of the vessel. And obviously, retrograde access now allows you to come up and identify the ostium of that vessel. We have found that most of the time it's easier to cross retrograde than antegrade and remain intraluminal. You're more likely to get subintimal. In many cases, if you go antegrade, and if you want to preserve all treatment options, particularly plaque modification or vessel preparation options, having intraluminal wire positioning is really critical. Then there's the whole idea of sort of primary pedal. When you get these cases where you just know from imaging or baseline angiography that it's unlikely you'll cross antegrade, we don't utilize a primary pedal per se, doing direct foot stick, but there are cases for a variety of reasons where that is the best approach. It might be a body habitus sort of issue or prior intervention failure, where we'll just bring them in with the intent to do the procedure from the foot, although that will, of course, require a larger sheath. And it's quite safe. I mean, there's some data here that you can reference, but the idea, the concern that we had that accessing a pedal vessel has long-term risk or complications or would jeopardize the limb turns out not really to be true. And there's a lot of ways to get both internal and external hemostasis and preserve flow through the forefoot and pedal arch. So where do you go? So some years ago at Viva, I was asked to give a similar talk, and that talk was angiosome directed. And I don't like the word angiosome because angiosome is based on surgical free flap technology, which is sort of based on normal anatomy. But, obviously there's a lot of variation in patients who have diabetes and chronic kidney disease who don't form normal collaterals and have variations in anatomy. I prefer the angiographosome. You do an angiogram, you sort of see where you're going to access. You're going to see what is the tissue blood supply, and that's where we want to try to puncture. We're trying to puncture in such a way, whether it be to treat antegrade or retrograde, that we're going to treat the vessel to the wound or target artery path or woundosome, depending on which terminology you like. And again, that's sort of this whole idea that's anatomically dictated based on the site of the occlusion, the quality of the access vessel. We can get into very densely calcified small vessels. That's definitely more challenging. And certainly within an outflow vessel, you're going to try to find a spot that's a little less calcified, a little better caliber, and also gives you some working room so you can get your wires in before you hit that distal cap. And this all plays in this whole idea of the anatomy of the vessel, calcification, tortuosity, and so forth. So here we get to Dr. Lee's slide set. He's taken the effort to sort of draw out these pictures of the normal anatomy in the foot and how you should do this. You really should just sort of do what you're comfortable with. Make sure the table's at an appropriate height, that you have, room under the II to work. You can angulate the tubes and not interfere. You can see the II and the monitor. So all these sort of play into your consideration about how you're going to do this. For AT-DP access, generally the foot's in a neutral position, as you can see here, and the foot is slightly plantar flexed, although as you do get in, it's very useful sometimes to dorsiflex the foot to help traverse the wire across the ankle where you have external ligaments and tendons which compress at that location. For perineal access, generally this is done on the inside of the leg. You can see the position of the foot here, and you want to try to get into a straight segment rather than into that perforating communicating branch, which is the terminus of the perineal artery into the anterior tibial dorsalis pedis and posterior tibial, respectively. Ultrasound is generally used. I think we sort of determined that earlier on today. Dr. Saab did an amazing job sort of showing that. Obviously, there's usually vena comitatus. We take advantage of this when we do our percutaneous arterialization of the deep veins, but you can identify the artery. You can use color flow here, use compression, and when you see, obviously, pulsation with compression, you know you're in the artery, and the veins will freely compress and won't pulsate. Also, as you can see, if you're good at this, once you get into the artery, then you can go ahead and traverse the lumen under ultrasound guidance. We use both transverse and longitudinal approaches. You know, I see here that Dr. Lee has said this better for this, better for that. I kind of think the best approach is sort of look at the artery both ways, and you sort of have a sense that, you know, what's going to give you the easiest approach. Remember that when you have your probe in a long axis, your needle at the end, you know, is sort of outside the visualized field. So you really have to get really close to that probe and get under it and sort of angle so until you can see the tip of the needle. The key thing is don't start advancing your needle if you can't see it. You know, so either way, you want to scan medial, lateral, up or down, so you can identify the tip of the needle as you advance it to make sure that you're not puncturing in any inadvertent sort of way. And again, the ultrasound's techniques, but you know, if you're comfortable with ultrasound and you're doing it yourself, you'll find that sometimes you go transverse, sometimes you go long, and often you do both, and you sort of switch back and forth as you go. And this is a nice pictorial that, again, Dr. Lee has done. This whole idea of sort of bouncing the needle, you can sort of see that on the right. You know, it's sometimes hard to see these needles, particularly against the calcified. As you approach that calcified artery, the tip of the needle becomes obscure. You know, kind of gets lost in that calcium. So by bouncing the needle, you kind of sort of see where you are, but you also get tissue reverberation. So again, it's important that you sort of scan medial and lateral to ensure that you're seeing the needle tip and not just sort of movement of the adjacent tissue. Now we can do much more sophisticated things. This is an example of metatarsal access, and this is from the literature, not one of mine, but sometimes with extensive calcification, there's no target zone. You got to do some of these novel things. In this case, metatarsal access, you can see here, is useful. Generally, this is not ultrasound guidance, although it can be. Generally, it's just using target artery calcium, as you can see here, or you can do a road map. If you're going to do a road map, I'm going to show you another case in just a moment, you have to sort of find the best vessel upstream of that supplies collaterals to the reconstituted vessel so that, you know, you're easier to see it and can see it real time as you puncture. This one is done with ultrasound guidance here. This is actually Dr. Swee's case with his permission. And you can see here him on the left as you're sort of doing this. And as in all of these things, you're looking for flashback. The key thing when you're doing any of these axes is that you're more prone to get deep to the vessel and when your wire doesn't go, and you don't want to pull out of the vessel. So, you know, what you can do is, let's say you've approached it in a craniocaudal fashion, your wire is not going, you want to go to an opposite oblique and then sort of pull back till you see that you're in the vessel. You don't want to come out of the vessel because that's a mistake. You know, you're going to get spasm, you're going to get bleeding, you're going to get compression at that site. It'd be harder to access. So generally, our natural tendencies is that when we pull off the hub of that syringe, is that we're pushing the needle in a little bit if the wire doesn't go freely, and you generally have to sort of come back. You can sort of spin it back gradually, rotate your hub up and down, and probe with your wire until it releases, but sometimes it's useful to do that opposite projection than you did your initial puncture, and I think that's actually a really useful point. This is what I was just talking about, sort of live angiographic or roadmap guidance. This is a patient just a couple of weeks ago. You can see a distal medial plantar sort of comes back way down over here. We looked with ultrasound, couldn't see this thing. It was very calcified and very small and very distal. But what we had done in this case is we had gone down the AT to its point of occlusion above the ankle, and to the PT to its point of occlusion above the ankle, and finally the perineal. And we put the microcatheter in the perineal so that that was the best collateral to reconstitute the vessel we wanted. So in the real time, while we did that, we could go ahead and, you know, while puffing, sort of see the artery, land on the artery. It's sort of like landing a plane, you know, right on this, you know, in the best view. Generally, you'll sort of see the artery kind of yield, and then hopefully let's go a little quicker. There, that was a little bit out, and then we go. So we're a little bit deep, then we sort of pull back and get the wire to advance, and confirm that we're in after exchanging with 3 French introducer. And of course, once you do this step, then you can go ahead and wire from below, and this is just to sort of show some fancy footwork, do the rendezvous from above and below. It's an 035 system from above and a 014, 018 from below to get through and complete the rendezvous. But again, we're not going to bore you with that. And this is the final result where you get straight line flow now out to the forefoot. So in conclusion, obviously we're treating more and more complex disease, more difficult patterns of anatomy. This requires advanced techniques. Pedal access is here to stay. It's numerous advantages. It's very, very safe. You can do balloon hemostasis, which I didn't talk about, and access site occlusion is very, very unusual. So appreciate your time.